This conference will now be recorded.
So welcome to the class. So in today's class, we'll be discussing the nice guideline about the diabetes in pregnancy and like overview of the talk, management of diabetic ketoacidosis in pregnancy, and also question answer. Okay. If anything that is not clear, so you people can stop me. Now, first important to know the diabetes classification. It is not new for us. We already know. So either it could be pre-existing. If the pre-existing diabetes is there, we know that there are two types, type 1 and type 2. And if it is a gestational diabetes, now there would be two types, that patient has previous diabetes, but during the start of pregnancy, the blood sugars are fine. She's not under any control, and she develops gestational diabetes. Okay, so this is pre-existing diabetes, but again, patient develops gestational diabetes. And true GDM, that means previous has been no history of any diabetes or a hyperglycemia, and the patient develops diabetes. Just an overview, this is not too much of important. So people, my voice is coming or not? Because someone wrote in no voice. Is my voice there?
Yeah, ma'am, it's clear.
Okay. So who the people who are not able to like listen, they please check their internet, and the screen is also clear.
Clear, ma'am.
Okay, fine. Now, type 1 diabetes. So, a little bit about the pathology we have to know. That helps in better understanding. So, type 1 diabetes usually occurs in a younger children. Okay, so you will find the people of younger age, like 14, 11 to 14, or less than 20 years that it presents. It usually occurs, like Caucasians, and patient will not be overweight. Okay, and the clinical features: thirst, polyuria, blood vision, weight loss, ketoacidosis, that we know. Now, what happens in type 2 diabetes? So, type 2 diabetes people usually older, okay, and they're overweight people, older and overweight. And the pathology is what? There is a peripheral insulin resistance. That means insulin is there, but like cells, they're not responding to that insulin. So this is the basic pathology here. And sometime the type 2 diabetes people, they will have hyperglycemia, and they will not have clinical symptoms. Because of that, whenever we diagnose the people with the type 2 diabetes, it is very important that we have to screen for any associated, like heart condition, blood pressure, or whatever the complication associated with diabetes. So this is a difference in the pathology, that is important to know. Then, what is pathogenesis? So, in type 1 diabetes, we already know there is an autoimmune destruction of beta cells of islet. Okay, because of that, like cells are not there, so they are not producing insulin. So, in the treatment of diabetes mellitus type 1, the treatment is insulin. Okay, because beta cells are destroyed, so less of insulin, so we have to give here what treatment will be insulin. So when you see your question in the in your exams, then you will find that patient is already taking insulin, so it is type 1 only. The type 1 diabetes mellitus, it station do come in part 3 exam. And in type 2, as we already know, that it is associated with the age, older age, and obesity, and the pathology is peripheral insulin resistance. So insulin is there, but tissues are not responding. So there is a difference here. I'm repeating it again. In type 1, beta cells are destroyed, insulin is not there, so treatment would be insulin. In type 2 diabetes, that most of people have, they will have peripheral insulin resistance. So insulin is there, but the tissues are not responding. So they very very easily responds to the oral hypoglycemic agent, metformin, glibenclamide. So all these are oral, oral medications, they will respond. But type 1 people do not. In type 2 people, we know it from our clinical practice also. If we have if they have, first the line of action will be giving, like oral hypoglycemics. If the patient is not responding, then we add insulin. So this is just a difference in the pathology, so there is a difference in the treatment. This is basic knowledge we know from our UG days, but a little knowledge is necessary. So how the people usually present classically. So you will find, in your question, the patient has recurrent infection, pruritus vulva. So you will have a thought of diabetes. Patients present usually with the skin infections. You will think of diabetes, and these are the macrovascular arterial disease and microvascular arterial disease associated with diabetes. So macrovascular would be coronary heart disease, cardiac problems, cerebrovascular disease, and the peripheral vascular disease. Okay, so in diabetic foot or whatever the things are there. So these are macrovascular arterial disease. Now, what will be microvascular? Diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. So sometime, in our questions they write microvascular, macrovascular. So you have to know what is a clear differentiation, that which are the macrovascular arterial disease and which are the microvascular disease. Though they're not asking that in a question, but it is important, that we should know that what is falls in which category. Now, though it is not, this is from the strategy, doesn't come in question, but you should know, children of parent having type 1 diabetes has got 5 to 6%. So type 1 people, their next generation will have diabetes in 5 to 6. Now see type 2, it is so high, it is 10 to 15%. Okay, so you can just remember this is 5 and this is 10. So it is double in type 2 rather than type 1. And the people and the mother who develop gestational diabetes in pregnancy, children likely to develop obesity and diabetes later on in life. Okay, now whenever the maternal medicine, we any topic we are doing, it is like it is very important to find out how the disease will be affected and how pregnancy will be affected. So effect of pregnancy on diabetes, what will happen? There would be alteration of the sugars, usually occurs in first trimester, so hypoglycemia. There would be inadequate control. What can happen is a ketoacidosis, increased tendency to infection. Okay, so this can happen. Apart from this, microvascular disease may worsen, nephropathy, retinopathy, and so all these are going to worsen. Okay, so this is the effect of pregnancy on diabetes, on diabetes mellitus. Now, how what will be the maternal complications? Okay, so that is effect of diabetes on pregnancy, mother. So maternal complication would be miscarriage, increased risk, gestational hypertension and preeclampsia, increased risk, prenatal risk, like more likely to be having infection, and cesarean sections are high. Apart from this, increase in infection, that means the UTIs, other infections, obstetric trauma, because we already know that there is a macrosomia. If the macrosomia baby is coming out from the maternal pelvis, chances of perineal trauma is high, that we already know. So these are the maternal complications that can happen if the diabetes is there. These are the fetal complications. So congenital anomalies. The first one is a cardiac. So maximum number of patients who have cardiac babies will have cardiac problem, renal problem, neural tube defects, microcephaly, and sacral agenesis. So if you have to see what happens the most, it is cardiac and also the neural tube defect, NTD. And if the sacral agenesis is there, that is the pathognomonic of having diabetes in the pregnancy. Though the sacral agenesis would be very rare, okay, very rarely you will find it. Commonly you will find NTD and cardiac, but if sacral agenesis they write in your question or you see ever in your practice, you have to think of diabetes. Hypoglycemia, baby can have it after born. There could be stillbirth, perinatal mortality. There could be polyhydramnios, injury because of the macrosomia, shoulder dystocia, fractures, brachial plexus injury, and asphyxia. Macrosomia can occur, and also FGR can also occur. Postnatal adaptation problems. So these are the fetal complication. that can happen if the fetal complications, or if the diabetes is there in the pregnancy. Okay. Now, pathophysiology of the fetal effect, important, good, important to know. So what happens there, if the diabetes, like if there is not controlled, so there will be maternal hyperglycemia, that will lead to fetal hyperglycemia, that will lead to fetal pancreatic beta cell hyperplasia, that will lead to fetal hyperinsulinemia. Now fetal insulin is high. Because of this insulin, there is macrosomia, there is organomegaly, there is polycythemia, there is hypoglycemia, RDS, and jaundice. Okay, this part is, you have to know, because the question comes from here. Okay, question comes from here. So these are the again I'm speaking, these are macrosomia, organomegaly, polycythemia, hypoglycemia, and RDS. So these are the fetal effects pathology, and it usually from here you will get question in the exam. So it is important you to know. Now, up to this was just basic about the diabetes. Now it will be the recommendations from the NICE guideline. Okay. So of like what they have divided nice, I have put the sequence same as there is in the NICE guideline. So understanding, and revision becomes easy. So the starting with the preconception counseling. Okay. So in the preconception counseling, there would be some dietary change, dietary supplements, and body weight. So according to the NICE guideline, there has to have a dietary advice that is individualized, that we already know. But what they want, when the woman with the pregnancy, diabetes, they're planning for pregnancy, so BMI should not be more than 27. So if you find in your part 3 exam or part 2 exam, anywhere they are dealing with the planning for pregnancy, you have to look at the BMI. If the BMI is given in the question more than 27, you have to advise them to lose weight. So and this is only one, this pre-pregnancy conceptional counseling in diabetes is the only one uh, place where they want 27 BMI and to lose weight. In all other cases you will find more than 30, they want you, the patient, to lose weight. But in diabetes it is the 27. So at 27 BMI they will advise patient to lose weight, okay, before she becomes pregnant. Apart from this, 5 milligram folic acid uh, will be given until 12 weeks of pregnancy, that we already know. So what are the indications where the high dose of folic acid is given? One of them is diabetes mellitus. Okay. And now before pregnancy, whenever the patient is planning, it is very important that her sugars has to be controlled. So how they are checking that? They are checking that by they are doing monthly measurement of glycosylated hemoglobin. And usually if the apart from this, patient can do self monitoring also when they are planning for the pregnancy. And if the patient has type 1 diabetes, okay, then they usually ketone strips are offered. And if any hyperglycemic symptoms, or if they feel unwell, then they have to test for ketones also in the with the strips. Okay. So these are all the things they want to assess the glucose control or blood sugar control before pregnancy. So all these tests are recommended by NICE guideline. Now patient will say, so okay doctor, how much glucose level should I have before I can plan pregnancy? This is the common question that is asked. So they can plan pregnancy if the targets are met. So target glucose range pre-pregnancy, before pregnancy, it will be fasting. It is 5 to 7. Okay. And glucose level at any other time before meal would be 4 to 7. This number you have to remember only. In UK, the sugar testing, whatever is done in millimoles per liter, So this must, you must know. Apart from this, the exam also you will get millimole so you have to remember that. Though we know that in our place we are doing in grams, milligrams, but there it is millimole. So remember this number. This is very confusing also, because targets for blood sugar control when the patient is pregnant is different. Okay, so please, you will find 2 3 times these targets will come. So this is targets for pre-pregnancy glucose. Okay, pre-pregnancy, the if the patient is able to achieve these targets, then we are happy with the control, and her diabetes is optimized. She can plan pregnancy. Okay, now this is the capillary plasma glucose targets. Now what about the targets of glycosylated hemoglobin? If it is more below 48 or 6.5, she can go ahead and plan pregnancy. Okay, there's no problem. But if it is more than 86 or 10%, then we have to say no to pregnancy, and even the patient should be offered a contraceptive. Okay, so whatever the levels, target levels that I wrote here, these are before pregnancy or pre-pregnancy, and every number is important here for 2 and 3 both people, because 2 people they will get direct question, and 3 people they will get a scenario, and from this sugar they would give you sugar level, and you have to decide whether your patient will can go ahead and plan pregnancy, or you will offer her contraceptive. So these numbers have to be remembered. There is no, shortcut. Now a patient sometimes is on some kind of medication. So what they say, safety of medication, if the metformin and insulin can be used before pregnancy and during pregnancy. Here there is an update. Okay, in 2015 when this guideline came, that time when we were I was reading for my exam, that time glibenclamide was also there in the guideline, but there had been 2022 update. According to that, they have removed glibenclamide from the guideline. Okay, now it is in whole guideline you will not find anywhere they have put clemide. Previously in pregnancy and breastfeeding, they were both the time they were giving it. Okay, but they have not given the reason why it has been removed. But clemide has been removed from diabetes in pregnancy and breastfeeding. So please remember this. If you guys will get question, you will get question from this part of guideline, because there had been a change. Now, so metformin and insulin can be used before pregnancy and during pregnancy. Rapid acting insulin, these Aspart and Lispro, they can be used. Okay, actually, I'll be just speaking about the insulin also. So, insulin is usually, 3 types of insulin is there. One type of insulin is long acting. Long acting is to insulin, like for I wrote it here only. Long acting insulin is like datimir or glargine. So they they usually have a longer time of action. So usually they are given once or twice a day. Okay, then there would be intermediate acting insulin that will work for some hours, maybe 8 or 6, exactly I don't remember. So intermediate insulin is NPH or isophane insulin, and short acting insulin, they will be like for 1 or 2 hours, or these very short period they will act for. Like if the patient has a glucose sugar rises just before lunch or whatever, so that's for short acting effect they usually given. Okay, so what they say, rapid acting, or that means short acting, aspartame lispro doesn't, there is no effect on the health of mother and baby. So that means in on the other side it can be used. Isophane insulin, NPH insulin is first choice in pregnancy. Okay, though they are saying it long acting here, but actually it is intermediate acting insulin. So isophane insulin is a drug of choice, or NPH insulin is choice to be used in the pregnancy. Now what they say, long acting insulins, that is detamir and galargine, before pregnancy they can be used before pregnancy they can also be used. Okay, that is insulin detamere and insulin glargine. Okay, so but if you get choice what type of insulin you will use, so you will speak about the NPH only. And what are the hypoglycemics we can use in whole pregnancy? That will be insulin and metformin. Okay. Now, apart from this, many of these patients, those who are diabetic, they have associated, metabolic syndrome. So sometimes they are on any antihypertensive, or they are on statins. So ACE inhibitors or ACE angiotensin 2 receptor antagonist, they should be uh, um, stopped before pregnancy, or or as soon as the pregnancy is confirmed. And why we are removing that? We remove that because they effect on the fetal kidneys. Okay, so we want to stop them. And all the statins like rovastatins or atorvastatin, what is the patient taking before, they has to be stopped before, as soon as pregnancy is confirmed. Okay, these are two kind of medication that has to be stopped pre-pregnancy. Okay, apart from this, so these are all about the medication change before pregnancy. So I have spoken about diet as folic acid to be added, and also mm, what are the medication to be stopped before pregnancy, and what hypoglycemics that can be continued during pregnancy. Now, what are the assessment has to be done? We already spoke about target sugar levels, and also I have already spoken about glycosylated hemoglobin. As we already know that there would be retinal involvement, and also there would be renal involvement. So retinal involvement before usually in UK, they are on regular checks. So retinal assessment, usually if it is not done previous last 6 months, so whenever the patient is coming to you with a pre-pregnancy counseling, retinal assessment has to be arranged. Okay, now the patient who are planning for pregnancy, and they should not allow for rapid optimization of glucose control until renal assessment has been happened. So now similar kind of thing you will find during pregnancy also. So if the retinal assessment has to be done before pregnancy, and you find that the patient is hyperglycemia, having uncontrolled sugars, that time uh, rapid optimization is not required. So slowly the patient sugars optimization has to be done. Okay, and in pregnancy rapid optimization is allowed, that we'll see in upcoming slides. So the take home message, that retinal assessment has to be done at the first pre-pregnancy booking if they have not done in last 6 months. Okay, apart from this, renal assessment. So renal assessment they are doing, like they will do all this kidney function test. And if like if serum creatinine is more than 120, albumin creatinine is more than 30, and EFGR, that is estimated glomerular filtration rate, is less than 45. These are the three indication. Patients will be referred to the nephrologist for renal assessment before they stop any contraceptive. So these are the checks this guideline recommends. So I'm repeating it again. Retinal assessment to be done. If it is not done in last 6 months, renal assessment is done. And if any time serum creatinine is more than 120 micromole per liter, urine albumin creatinine ratio is more than 30, and if EFGR is less than 45, patient to be referred to nephrologist before she stops her contraception. You will find question from every line here. Apart from this, so these are the checks they are doing. Now this is the thing that everyone has to know, and the or people make mistake. Like in our countries, in all other countries, Usually sugar testing is done for all pregnant patient. Okay, it is just like a routine for we us people, but in UK every woman will not be assessed for the sugars, or sugar check is not universal in UK. These are the five indications. These are the five indications. Only if the patient has got these indication, then only they will be doing sugar testing. Okay, so this mistake, most of the part 3 people do that in every station. When they are doing, they'll do sugar check, but no, only these are the five indication, and you have to learn it by heart. Like in hypertension, we have got a certain indication, moderate and severe risk factor, where we would aspirin. So we have to remember that. And similarly, in diabetic guideline, you have to remember that what are the risk factor with which you will offer sugar testing. Now, so BMI more than 30, previous macrosomia, baby weighing more than 4.5 kg, previous GDM, family history of diabetes, first degree relative, ethnicity with a high prevalence of diabetes, like Asian countries. And so if these risk factors are there, then only patient should be offered glucose testing. And what is the choice of test? That is 75 grams 2-hour glucose tolerance test, and it is done at 24 to 28 weeks of pregnancy. So this you have to remember, and because otherwise people make mistake in doing their questions. So these are, I'm repeating it again. In UK, at booking visit there would be risk assessment. If patient has BMI more than 30, macrosomia more than previous baby, weighing more than 4.5 kg, previous GDM, family history of diabetes, like first degree relative having diabetes, or patient belongs to ethnicity that has got high prevalence for diabetes. These risk factor if are there in your question, then you will arrange sugar testing, and the sugar testing is done with the oral glucose tolerance test at 24 to 28 weeks of pregnancy. This is 75 gram and 2 hours. Okay, so this also, lots of question will come from here. Now if the patient comes to you that have GDM in previous pregnancy, and this is second pregnancy, so what to be done? uh, she can self monitor her blood glucose, or so OGTT can be done anytime as soon as possible after booking visit. And so this will be one test. Apart from this second test that we do for all women with the risk factor, this will also be done like 75 gram 2-hour OGTT at 24 to 28 weeks of pregnancy. If the first result of OGTT are normal, that is obvious. If first result has come any issue, then you will start treating this patient. But if first test comes normal, then you will rearrange OGTT at 24 to 28 weeks of pregnancy. So you will find this is also very important, because you will find many questions from here. Okay, now how you will diagnose GDM? This again, the two numbers that you have to remember. If the fasting level is more than 5.6, and 2 hour pp 2 hour plasma glucose level is more than 7.8. If either of the value is high, then you will you will say label the patient as GDM. Another simple way of remembering the diagnosis of GDM: 5, 6, 7, 8. Okay, these are chronological number. So this is so just you remember fasting 5, 6, 2 RPP 7, 8. Okay, so if you remember this way, because when you have to solve question, remembering all these target levels becomes very difficult. But this diagnosis of GDM number, I find it easy, because it is in the chronological uh, order of 5, 6, 7, 8. Okay, so only one, it is not that both values has to come positive, then you will label the patient as the GDM. Having one value positive, also you can label the patient is having GDM. So now coming to what the guideline says about the treatment of GDM. So first and foremost is lifestyle, that is switching over to high food of high glycemic index to food of low glycemic index. So this is the diet change. And exercise, 30-minute walk after a meal. Okay, so they will review, they will give the diet and exercise advice. After that they will see the patient 1 to 2 week time. If it is not controlled, then what will be the next step? First we'll try with the oral tablet, so metformin. Okay, but next step, if the blood glucose are not targets are not met with diabetes, with the diet and exercise both. So you have done diet, exercise and metformin, but still the sugars are high. You left out only with one option, that would be insulin. Therefore, this way the treatment plan will go. First will be diet and exercise. That will be for review the woman in 1 to 2 weeks. Not controlled, offer metformin, review the patient again. If it is not controlled with all three these measures, then patient to be offered insulin. So just remember this small few points, and your answering about the questions become very easy. So on the other side, now we know that seven, more than seven will be the diabetes or like high sugars. So if the patient has GDM and you do FBS, and FBS is more than 7, because our target level was 4 to 7, fasting was 4 to 7. That the target we read, pre-pregnancy target 4 to 7 fasting and 5 to 7 at any other time pre-meal. So if patient has GDM and fasting is more than 7, what you will do, you are dealing with a patient of uncontrolled diabetes, so you will immediately start the treatment with insulin, because you have got. I would request all of you to mute yourself. Okay, so like if the patient has GDM and fasting blood sugars more than 7, that means we are dealing with a patient of uncontrolled diabetes. Now we would be in hurry. We have got no time for diet and to review the patient, because that will start affecting baby. So we have to act fast. How we will act fast? We will offer immediate treatment with insulin plus minus metformin, and diet and exercise will always be there. And if the patient, so this is, you will get question from this line. And also this is very important, if you find GDM and the sugar levels are 6 to 6.9, 6 to 6.9, but associated macrosomia or hydramnios. The macrosomia and aminos is also indicator for uncontrolled diabetes. What you will do, you don't have time, treat the patient fast. So treatment would be with insulin, with or without metformin. Diet and exercise changes would be there. So this will help you in answering question, because they will give a number of levels. So if you have got a clear idea what is a recommendation by guideline at that level and associated complication, then your life easy. So till here, I spoke about the GDM and the basics of diabetes. Any one of you have got any question before I move ahead with the antenatal care? Any question till now? Okay, no question. Then when we move ahead. So now, first I'll be speaking whatever given in the guideline about the antenatal care, then intrapartum care, then postnatal care, and neonatal care. Okay, this way, similar way, the guideline goes also. So antenatal care. Now, what will be the frequency of blood? Now the patient is pregnant, and how you will arrange antenatal care for the woman. So, frequency of blood test. Now, see here, if the patient has type 1, type 2, or GDM, and the patient is taking multiple insulin, many times she is 2 3 times she is taking insulin, so you would like to see blood sugar level, fasting, pre-meal, 1 hour post meal, and bedtime. Okay, so the fasting, pre-meal, 1 hour post meal, and bedtime, this much the blood sugar frequency. But if the patient is controlled, G2 type 2 patient or GDM patient, control on diet, exercise, or only one dose of insulin she requires, then the insulin testing will be fasting, pre-meal, and 1 hour post meal. Okay, so this though they have not asked this question, but yeah, it is important that you should know about the frequencies. Now, this slide is very 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 important. Now uh, these are the targets in pregnancy that the patient has to achieve. Now, we have read first we read target in pre-pregnancy counseling. What should be the target pre-pregnancy? So that was 4 to 7 fasting, and 5 to 7 at pre-meal any other time of the day. So these were the target we read in pre-pregnancy counseling. Second number, what we read in the diagnosis of GDM, that was very easy. I asked you to remember 5, 6, 7, 8, that is fasting and 1 hour. Now these are the third target that you have to remember. So these are the targets that has to be achieved when the patient is pregnant. Okay, so because you have to give some idea about the to the patient, how much level she has to achieve. So these are the targets. No excuse, but you have to remember these numbers. So fasting is for 5.3. Okay, and 1 hour 7.8, and 2 hours 6.4. Okay, so 1 hour was same previously also in GDM, and here the 1 hour is same for 7.8. So fasting is 5.3, 1 hour 7.8, 2 hours 6.4. Okay, apart from this, the patient, so these are the targets we want to achieve. But for the women who are on insulin, they have to maintain their level above 4 millimole per liter. Why? Because we are worried about the hypoglycemia also. So if the patient is on insulin, just give them advice. Please adjust your doses. We want your level sugar, capillary plasma glucose level to be above 4 millimole per liter. Okay, so please remember these numbers. Now, this is again uh, checks for, like, there are certain indications, and when they are checking glycosylated hemoglobin. So first, if the patient has pre-existing diabetes, then they will check at booking visit. They will check if the patient pre-existing diabetes, they will check in second and third trimester. But if the patient has GDM, then also they will check it, because they want to know whether patient has previously any associated type 2 diabetes mellitus. Okay, so I'm repeating it again. For the in the women with the pre-existing diabetes, they would like to check glycosylated hemoglobin at the booking visit, and also in the second and third trimester of pregnancy. But if the patient has GDM, then they will also do it, because they want to know whether any all pre-associated type 2 diabetes mellitus is there or not. So this is all about the glycosylated hemoglobin check. Now insulin. So insulin, like can be, like long acting, rapid acting. This we read before also, same they have repeated in more detail. So short acting lispro aspart can be used in the pregnant woman, and insulin treated women, we already know that they can develop hypoglycemia. This is the main trouble. So we have to advise them that glucose containing drinks, or dextrose tablets, or glucose containing drinks, they have to keep with them. Type 1 diabetes mellitus people, they are very high risk for having it. So they should be given glucagon injection. Apart from this, this they have said about the insulin. Now, another thing that has been introduced newly in this guideline, it was given in previous guideline also, but it was very less, little less details given. So they want continuous subcutaneous insulin infusion, CSSI, that is also known as insulin pump. So insulin pump, like usually, like what we have read till now, there would be diet change, there would be exercise, there would be metformin, and there would be insulin. So they are giving insulin in like one dose, two doses, but there would be many patients. They will not be settled with all this treatment. So sometimes they have to take multiple injection of insulin. Sometimes, in spite of taking insulin injections, they still develop hypoglycemia or they're unable to control sugars. For these kind of patients, what to be done? They can be offered like insulin pump, that is a subcutaneous continuous insulin infusion. So insulin pump is also there. Okay, so insulin pump, they have they it do have an like technology. So without patient having going sugar slow, so there would be release of insulin will be there accordingly. So these are continuous insulin, subcutaneous insulin infusion or insulin pump. Now these few things I was saying before also. So there would be like short acting insulin, acting insulin aspartate and lispro, they act more fast. So this way the short acting will act. So you can just, nobody is going to ask in the exam, just for your knowledge. So short acting, I said 3 to 4 hours. So basically their maximum effect will be 1.5 hour and decrease to 0 by 5.5 hours. So this way the short acting insulin will act. Okay, and isophene will be the intermediate acting insulin, and galargine and datimir, these are the long acting insulin. So this way the long acting insulin can act. Now you can see that maximum effect will be in 6 to 12 hours, and usually duration will be 24 hours. So it will act like this. So this is long acting insulin. Because of that, long acting insulin usually we have to give once or twice, so less doses would be required. So nobody is going to ask that, but just you have to know this. So repeating it again, so short acting insulin is lispro and aspart, can be continued in the pregnancy, they act fast, so this is short acting. Intermediate acting will be insulin isophene. Usually that is the insulin of choice recommended by the guideline and of the choice. Long acting insulin are datimir and levimir, that is also can be given during pregnancy, and this will be the like this way, like this will be there, um, like working. So these are long acting insulin. So the more than that is not required for your exam. That we need to know that three types of insulin and type of choice in pregnancy is isophane. Now there has to have a multidisciplinary approach. So who will be the people from the diabetic team? Endocrinologist, obstetrician, diabetic nurse, and dietitian. So this will be the person in the multidisciplinary team of a diabetic patient. Now these are two things that has been newly added in the guideline, not in detail, but you should know. So insulin pump was, in like it was continuous infusion of insulin. Now this is all about insulin monitoring. Now there are two types of continuous glucose monitoring. So one is real time, and that is RT-CGM. Another one is intermittent scanned glucose, that is ISCGM, that is also called as flash method. Okay, so this is real time and this is flash method. No one is going to ask you from this in the exam. This is for your self understanding. So this is the real time glucose monitoring, that is RTCGM. Usually they have a sensor. So this sensor will be put inside, like at the subcutaneous level. It is inserted under the skin. So this is inserted under the skin, and then they will be connected to the transmitter, and so it will be attached to the monitor. So continuously glucose level can be seen on the like monitor. So this is the monitor. So continuously monitoring can be done. So this device, they have sensors, so they will sense the glucose and they will send the data to this handheld device. Sorry, this they will transmit the data here. So so continuously the sugar checking is getting done. And this use whenever we do blood glucose testing, whenever we are doing glucose testing, so we are checking on the that was the capillary glucose testing, but this is inserted inside, and they are checking interstitial glucose level. So in interstitial fluid they are checking insulin glucose level. So this is also the difference. So this is real time or continuous glucose monitoring. Another system of glucose monitoring, that is intermittent scanned glucose monitoring. So here there would be there would be a probe like this, and there will be a device. So they have to scan it whenever patient wants to, whenever the patient wants to check blood sugar. So they will be scanning it. So here it is when the patient want intermittent scanning, and here it is continuous glucose monitoring. So it is RTCGM, and this is intermittent scanned, that is flash glucose monitoring. So this part has been added in newly in this guideline. Previously this was not there. Okay, so this same thing I have already told. So what the guideline says: offer RTCGM to all pregnant women with type 1 diabetes, where that will help to meet pregnancy blood glucose targets and improve neonatal outcome. Okay, so this is recommendation by NICE. Apart from this, what they say: offer intermittently scanned glucose monitoring to the pregnant women with type 1 diabetes who are unable to use RTCGM, or they don't want to use it. Okay, so if the patient says no, I don't want continuously monitoring, so then they will offer ICGM or flash method. Okay, so these are two types of monitoring method. For we as an obstetrician, this much is enough. And what the guideline says: the RTCGM to be done if the patient has severe hypoglycemia. You give insulin, she will be hypoglycemic, and you will never be able to know. For these kind of patient, continuous monitoring is required. Another set of patient, whatever you give, the sugars are not getting control. For them also, you want continuous watch on their blood sugar levels. So these would be the indications for RTCGM. Any question till here? Any question till here? No question. Okay. Now, ketone testing. Actually, we know the ketone, hyperglycemia, usually the common complication associated with type 1 diabetes mellitus. So usually they are given ketone strips. When this patient they feel unwell, then they will do ketone testing, and if the test come positive, they will seek urgent medical advice. Okay, and when the patient is coming with a diabetic ketoacidosis, so they have to get admitted in level 2 critical care. Okay, level 2 critical care when one system support is required. Okay, so this is about diabetic ketoacidosis and ketone testing, they are saying. Now previously we read retinal and renal testing when the patient was planning pregnancy. So we read retinal and renal testing pre-pregnancy. Now, what will be the difference if the patient gets pregnant? So, whenever the patient is coming for the booking visit, that time renal testing, retinal testing will be done if renal assessment was not there in last 3 months. So here is a difference in between pre-pregnancy and pregnancy. If the patient coming you with a pre-pregnancy counseling, then retinal testing will be offered if it is not done in last 6 months. But the pregnant patient, we have got less time, so the renal retinal testing will be done if she has not done her testing in last 3 months. Okay. Now there would be uh, two situations that they will find retinopathy. If the retinopathy they will find, additional testing will be done 16 to 20 weeks of pregnancy. But if they don't find any problem with the retina or eye test, then another retinal testing will be offered at 28 weeks of pregnancy. So that is important to know. So if the patient with the in the pregnancy, do retinal test if not done in last 3 months. If it is normal, then repeat at 28 weeks. But if it is abnormal or the retinopathy is diagnosed, additional retinal test to be done at 16 to 20 weeks. All these numbers are important because you guys will get question from here. Apart from this, if the diabetic retinopathy is there in the pregnancy, rapid optimization of blood glucose control can be done. So this we were not doing in pre-pregnancy because time is not an issue, but in the pregnancy we have to act fast. So rapid optimization of blood glucose level can be done. Apart from this, diabetic retinopathy is not a contraindication for vaginal birth. Whether there have been a part 3 station where the patient has got problem with the patient has got diabetic retinopathy and they were asking about the mode of delivery. So please guys understand that if the diabetic retinopathy is there, there is no problem. Patient can go ahead with the vaginal birth also. Now renal assessment. Again, in pregnancy, we would review the kidneys if no assessment has been done 3 months. Now, the nephrologist to be sent, they will refer to the patient to nephrologist when if the creatinine more than 120, albumin creatinine more than 30, and total protein is more than 5 gram per day. That means patient is having proteinuria. So that these are the indication where during pregnancy dermatologist nephrologist has to be referral to the nephrologist would be required. And this is a difference, EGFR we were using pre-pregnancy. In pre-pregnancy, if EFG EGFR it was less than 45, we were referring the patient to a nephrologist. But EGFR has got no importance in the pregnancy because there are so many vascular or cardiovascular changes occurs in the pregnancy. So EGFR will have usually no role during pregnancy. So in pregnancy they are measuring serum creatinine, so urine albumin creatinine ratio, and also total protein excision. If exceeds more than 5 grams, then in that particular situation, nephrologist, they will be patient to be referred to nephrologist. And like if a proteinuria is nephrotic range, that means more than 5 gram per day, thromboprophylactis to be added to women. Okay, so this also you should know because maybe asked in your exam, so it is important to know. This is the renal assessment during pregnancy. Now, these are the mothers. So, for mother, we read about the frequency of sugar check, about the renal testing, about the retinal testing. What about the baby? So, baby, they would be 20-week scan, 20-week scan, that is the anomaly scan, where they will do the complete head to toe scanning. With majorly, they will see heart and the four big vessels because cardiac problems are associated during pregnancy. Apart from this, there would be serial growth scan for every 4 weeks from 28 weeks of pregnancy. So this way, they will do fetal monitoring. Now this is the same. That is a summary, given in the guideline also. So whenever you see a patient that is a pregnant, and diabetes, so diabetic patient will be seen in a joint diabetic and antenatal clinic. Booking visit should be ideally by 10 weeks. They're recommended by the NICE also. So this is the same thing I have just spoken. Retinal assessment and renal assessment to be repeated if it is not done last 3 months. Antenatal check every 1 to 2 weeks. Glycosylated hemoglobin, it is measured to find out whether pre-existing diabetes is there, and if the patient has got previous GDM, then self-monitoring of glucose or OGTT and viability scan at 7 to 9 weeks. So this is the antenatal care that will be done if the patient is coming at the booking visit. Now, if on the 16 visit weeks, what will be there will be, if the first visit a retinal test was abnormal, so they will redo it. They will redo it, okay. And if the patient with the GDM, she is coming to you at the 16 weeks, so OGTT to be done to know whether pre-existing diabetes is there. At 20 weeks, we already know there would be 20-week scan, where 4 chambers, outflow tract, and 3 vessel they will see. 28 weeks, there will be retinal assessment for patient who had previously existing diabetes, and like and 28, 32, and 36 weeks there would be growth scan, that's we already knew. And at 36 weeks they will discuss about the time, place, mode of birth, anesthesia, analgesia, change in blood glucose lowering medication during labor and uh, after birth, care of the baby, starting of breastfeeding, so contraception and follow-up. So every all these checks will be done in the 36 weeks. Now, if this will be the time where we want to be patient to get delivered. So if the patient has got type 1 or type 2, we want them to deliver anywhere in between 37 to 39 weeks of pregnancy. And if patient is not delivered, then the fetal well-being has to be assessed. GDM patient, we want them to deliver by 40 weeks plus 6 days, okay. So this you will get a question from here. So this is the just summary of the antenatal visit and how the tests are done. Okay, now what the guideline says about the preterm labor. So if the patient is came with a preterm labor, so it is not a contraindication for any tocolytics or any antenatal steroids. Antenatal steroids can be given, but in the hospital, and also additional insulin would be required. So and the patient has to be managed closely. So the steroid can be given, but in the hospital setting with the monitoring, and change additional insulin would be required. Apart from this, beta mimetics medication or tocolysis should not be given in the patient with diabetes. Why? Because beta mimetics cause hepatic glycogenolysis. So there would be increased sugar levels. Okay. So because of the increased sugar level, so it will cause trouble in the control. Because of that, beta mimetics should not be used for tocolysis in the woman with diabetes. Okay. Now, that's all about the antenatal care, whatever mentioned in the guideline. So, any one of you have got any question till here? Okay. Now, what the guideline says about intrapartum care? So, time and mode of birth. This is very important, and you will get a number of questions, even the part 2 and part 3, both people. If the patient has got type 1 and type 2 diabetes and no complication, that means the pregnancy is going well. We want to deliver them by 30, in between 37 and 39 weeks of pregnancy. That is 37 or 38 weeks plus 6 days. Now, if the patient of type 1, type 2 diabetes mellitus having fetal complications, okay, maternal complication is there or fetal complication is there, so we can deliver even before 37 weeks also. And if the patient with GDM, we can wait till 40 weeks and 6 days of pregnancy. Okay, so we want by this time either it will be spontaneous birth or it will be induced birth. So these are the time scales that is important to be remembered for your exam point of view both part 2 and part 3 people. Now, if usually in the third trimester, they would be meeting with the anesthetists to discuss about the pain relief options. Because if the comorbidity such as patient is diabetic and obese, and if the any autonomic neuropathy is there, then high risk patient to be seen in the should have an anesthetic assessment in third trimester of pregnancy. Apart from this, if the patient is given general anesthesia during labor every 30 minutes from the induction till the baby is born, or the woman is fully conscious, so every 30 minutes there will be blood sugar check. Okay, you will find this the question from here. Now, if during labor, what will be the glucose monitoring? So, glucose monitoring will be every hour. And what will be the target? More than 4. That is, it should be in between 4 to 7. It target will be 4 to 7. Then, but if the targets are not met, then consideration for like IV dextrose and insulin infusion can be done. And if the patient has type 1 diabetes, then there is no other option. The IV that is the IV dextrose and insulin infusion to be added. So during labor, they will check glucose every hour so that it has to be in the targets 4 to 7. Type 1 people, they would be sliding scale insulin, dextrose and insulin infusion. For other women, if they are unable to control sugars, then they will sugars in between 4 to 7, then they will add that IV dextrose on one side and insulin infusion on other side. So this is neutralizing dose what we add. So this will be this way the glucose monitoring will be done during labor. So any question till in the labor or anything? Okay, postnatal care. Now this would be important. Now we have got 3 type of patient. The patient number 1, if the patient was previously treated with insulin, then post delivery there would be decrease in the dose. So dose of insulin will be reduced. Okay, if they are taking insulin in the pregnancy. If the patient was have a GDM in the pregnancy, then the GDM is the pregnancy induced sugar. Whenever the delivery is there, the glucose like the sugar will come back to normal by itself. So all glucose lowering therapy or all hypoglycemics to be stopped. Okay. Now, type 2 diabetes women who were on oral dose of metformin, they they can continue with the metformin only. Dose adjustment has to be done accordingly. So GDM people should stop any hypoglycemics, and the type 1 patient who were insulin treated has to reduce the dose of insulin, and type 2 patient they have to continue with the metformin, but the dose has to be changed. Okay, so in nutshell, in pregnancy there is an increased requirement for insulin or oral hypoglycemics that would fall once the baby is there. Okay. Apart from this, if the patients are treated with insulin, risk of hypoglycemia is there. So the patients are advised, like before or during feeds, to eat some meal or to some snack to avoid that hypoglycemia. Okay. So apart from this, so this was the postnatal care. Now after pregnancy, what will after postnatal care, what they do? They want to because in UK like at 6 weeks there is a postnatal visit. In the postnatal visit, what they do here in the diabetic woman, they offer lifestyle advices including weight control, diabetes and exercise, and they will do FBS at fetal fasting blood glucose at 16 to 13 weeks to exclude diabetes. Okay, so from here you will get a lot of questions. But if the patient has not come to you till 13 weeks, she is coming after 13 weeks, what you will do? So after 13 weeks, if the patient is coming, And FB fasting blood sugar glucose test has not been done, so you can do glycosylated hemoglobin. You can do diabetic glycosylated hemoglobin. So in a summary, if the patient is coming to you 16 to 13 weeks, please do FBS. If the patient is coming after 13 weeks of delivery, please do glycosylated hemoglobin. Now there are certain ranges are there. You have to at least know this, because remembering so much sugar ranges become difficult. At the postnatal test, if the fasting is less than 6, then we are happy. We'll ask this woman, please get your blood glucose test done every year. Annual testing would be required. But if we find that it is in between 6 to 6.9, then we would refer them uh, to get advice for prevention of diabetes mellitus, because they are at risk. And a third set of patient, we find FBS is more than 7, so we are dealing with the diabetic only, so they would be confirmed, and accordingly the treatment for diabetes would be started. So the question comes from first line: if the FBS is 6, what to be less than 6, what to be done? So answer would be annual test to check whether the glucose normal or not. Now this was the limits when they were using FBS in the postnatal visit. But if they have used glycosylated hemoglobin, then the limits are different. It is very difficult to remember this. Just review them once. If the FBA glycosylated hemoglobin is less than 5.7 or 39 millimole, then there is a low probability of diabetes. Annual blood test. And if it is in between 39 to 47, that means in between 5.7 to 6.4, they have got a risk of developing diabetes. They should be offered advice for prevention of diabetes. Last kind of patient where already more than 48, so we are dealing with a diabetic patient, that they should be done test, so that we can confirm that. Accordingly the treatment would be started. So you will get question from here and here, but usually they ask this level only, so that the life is easy for you. So that's all about the postnatal checks. Now postnatal care for the baby. So for the baby, we know that once the baby is born, the baby will be at a risk of hypoglycemia. So we want the sugar test to be done every 2 to 4 hours after childbirth. Baby are at a risk of polycythemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia. So if any clinical symptoms are there, then testing would be done accordingly. If the patient has got any heart condition or cardiomyopathy or murmur, then fetal cardiography to be arranged. Okay, so these are few things you should know. You may get question, and they can be transferred very safely to the community if their blood sugars levels are maintained and the patient is feeding well, baby is feeding well, and at least they are 24 hours old. Okay, so this much knowledge about the postnatal care of the baby is necessary. Now again the neonatal care. So baby to be, because they are at a risk of hypoglycemia, so as early as possible the baby should get feed. So like usually started within 30 minutes, and it should be in very frequent interval every 2 to 3 hours. But if and they do blood sugar test also for the baby, and if it is like pre-feed, it is minimum 2 millimole per liter to be there. But if their baby's blood sugar level is less than 2 millimole on two occasions, then additional glucose such as tube feeding or IV dextrose to be given to child. Okay, or if they shows any abnormality, if they are not feeding well, the babies are very high risk of developing hypoglycemia. So these kind of the conditions where baby to be started with the tube feeding or IV dextrose. Okay, so whenever the clinical signs of hypoglycemia is there, so baby should be given IV dextrose as early as possible. So this is what they said about the neonatal care. So any one of you have got any question till this point? Any question? No question. Okay, so that's all about the, diabetes, a nice guideline about the diabetes in pregnancy. It is a very important guideline for part 2 people and part 3 people. So, do this guideline very well, because they will ask you question from where in the middle. Unless you have got thorough knowledge about the guideline, then the question easily becomes wrong. So, diabetic ketoacidosis of pregnancy is only few things you have to know. So, I'll be just speaking very less about it. So, you have to remember the diabetic criteria for. And there had been a talk about the diabetic ketoacidosis in pregnancy, and I have taken whatever I'm speaking from that talk. So, diagnostic criteria for diabetic ketoacidosis of pregnancy: blood ketone level more than equal to 3, urine ketone level more than 2 plus, blood glucose level more than 11, and bicarbonate level less than 15, and pH level, venous pH level less than 7.3. So minimum the ketone level and blood glucose level you have to remember, because you will get question from there. Apart from this, what are the precipitating factor for diabetic ketoacidosis? If the patient has too much of vomiting, or hyperemesis gravidarum, if the infection is there, patient is non-compliant. That means whatever the insulin we have advised to take, they're not taking. Any medication that provoke it, insulin pump failure, that means the insulin patient doesn't know and patient is not getting insulin. There had been a hyperglycemia, or conditions uh, like gastroparesis. So these are the precipitating factor for DKP, and these are the features with which the patient will present to us. There would be nausea, vomiting, abdominal pain, polyuria, polydipsia, blurred vision, drowsiness, lethargy, altered mental state, hyperventilation, that is a hyperventilation or Kushmal's breathing, or pear drop order, that will be the characteristic feature of it, tachypnea, hypotension, tachycardia, coma, shock, and abnormal fetal heart racing if the patient is pregnant. So these are the symptoms and signs of diabetic ketoacidosis in pregnancy. So what these are the investigation they will show. So ketone will be positive. We Because we know the if it is more than 3, then it is diabetic ketoacidosis. Urine ketone may be positive. Hyperglycemia may be there, like more than 11, but sometimes it can occur at the lower glucose levels also. Low bicarbonate level, increase like arterial pH would be less, anion gap would be more, base deficit will be like less than equal to 4, and potassium level may be falsely normal or elevated. Though just knowledge, knowing once about that is very important. No need to remember this, because they are not asked in the exam. Main important thing that you have to remember here is the diagnostic criteria and protecting factors, clinical features. Now management. So management will be under these guide headings. Okay, let me I have taken the same charts from the talk. So first will be IV fluid. So the question will come, use these are the charts from where you will get the questions. So we have to give, when the patient comes with diabetic ketoacidosis, we have to give IV fluids. So IV fluids will be 0.9% normal saline at the rate of 10 to 50 ml per gram per hour. You will get question from this line. Okay. Then when the blood glucose level falls down below 14, then 10% dextrose would be added at a rate of 125 ml per hour. Okay, so this is the first line treatment, fluid of choice, and this is the doses. You will get question from here. It is very important. Second, we move to the potassium and insulin therapy. So usually the insulin therapy is guided by the potassium level. So we will do potassium level. Normal potassium level are 3.5 to 5 that we know from our knowledge. So if we find it is less than 3.3, that means potassium is less than normal value. What will give? Do here? Will only we supplement potassium, and we will not give IV insulin. And when we are offering potassium, will make it sure that the kidneys are working well, and the urine output should be 30 ml per hour, or it should be 0.5 ml per gram per hour. Okay. Now when the insulin becomes with so why we are not giving insulin if the potassium levels are low? That answer I can give. So what will happen if the potassium are low, and if we give insulin, then this insulin will push potassium into the intracellular space. So in cells there would be more potassium. Because of that, uh, it will aggravate the pre-existing hypokalemia, and it will lead to fetal cardiac arrhythmias. So insulin, and because of this situation, insulin should not be given until the potassium level are controlled. Okay. So uh, uh, so this is, if it is less, because of this reason, if the insulin, if the potassium level is, it is a hypokalemia, then please give only potassium, no insulin. Now second level, if it is in between 3.3 to 5.5, so it is like we can give both insulin and potassium. Okay, you have to remember this. Okay. Now if it is more than 5.5, so we are dealing with hyperkalemia. If the hyperkalemia is there, then will not give potassium, will only give insulin. So this way you have to remember it. I'm repeating it again. Hypokalemia, give insulin, give potassium, and no insulin. If it is 3.3 to 5.5, that is in between, give both insulin and potassium. If it is more than 5.5, we are dealing with the hyperkalemia. So we will give only insulin. You will get question from this here also. So there is a fixed rate we are giving insulin infusion, that is 0.1 unit per kilogram per hour. You have to remember this number, because you will get question from here. And if we have to increase insulin, then it will be 1 unit per hour. So remember these both two numbers from where you will get the question. So insulin is infusion started at fixed rate of 0.1 unit per kilogram per hour, and if we have to increase, it will be 1 unit per hour. Okay. And once the insulin level, now our insulin levels has come back to normal, so patient will be IV insulin will be continue for minimum 1 hour from the first dose of subcutaneous insulin. So IV insulin will be continued for 1 hour more, because we have to stop IV insulin, we have to put the patient on subcut insulin. So but when we have given subcut insulin, still the IV insulin will continue for at least 30 to 60 minutes more. So this is all about the potassium placement and insulin therapy. And now third cause, why the precipitation has been done, why the patient got diabetic ketoacidosis. So we have to take history, we have to do physical examination to find out why it happened, what was the precipitating cause. So CBC can be done, urine analysis and culture, because infections or like hyperemesis. This could be these are the reasons for the like precipitating factor for diabetic ketoacidosis. Patient monitoring. So how will okay, blood glucose level every hour, ketone level every 2 hours. First hourly, then 2 hourly. Apart from this, electrolytes, creatinine, um, like should be done frequently, uh, until every 2 hours, until it is stable. So blood glucose hourly till stable, ketones hourly initially, then 2 hourly, and electrolytes 2 hourly till the patient is stable. So patient monitoring is done this way. The question is not coming from here. Fetal monitoring, what we'll do? We'll do either scan or CTG. and depending upon the whole patient scenario, then the delivery is required or not will be decided. So this way the management of diabetic ketoacidosis is done. So question will come from the IV fluid number. Question will come from um, uh, um, insulin doses, and question will come from what type of treatment depend on the potassium level. So this is very important. So to uh, to know the management of diabetic ketoacidosis of pregnancy. This part I have already explained. This another line I want to tell you, because question comes from here. Usually, when the diabetic ketoacidosis occurs, there will be CTG changes. So, how long the CTG changes will come back to normal? Answer is 4 to 8 hours. Okay, so you will get question from here also. That much knowledge about the diabetic ketoacidosis is required. With this, like I have done with whatever I have to speak according to NICE and the talk. Now I'm open to questions. Before we start question, if any one of you have got any problem, you can ask me. Then we'll be doing question. Any question till now?
Ma'am, one question regarding the screening in gestation in diabetes. When we have cases of polycystic ovarian syndrome, or when we read the obstetric cholestasis guideline, it says that we should offer the screening. So, at what stage do we do it at booking and then 24 to 28 weeks, or it's only one time screening?
No, see, according to this guideline, PCOS doesn't come under any screening. PCOS doesn't come under any screening. In PCOS, they have got different criteria. Like if the, I don't remember at this moment, but if it is like patient is more than 25, then they are doing yearly testing. So that is, gynae part of it. So that testing every year to be done with a GP. That is not related to pregnancy. So PCOS, they are like there is no guideline as such that it should be done with the screening. Uh, uh, and apart from this, next what you said,
The
PCOS is
obstetric
not
cholestasis, ma'am.
in obstetric cholestasis, a guideline that is newly has come. In the obstetric cholestasis guideline, they say the patient who are having obstetric cholestasis, they are very high possibility of associated comorbidities as GDM and preeclampsia. So it will, but there is no specific guideline. Maybe if the patient has obstetric cholestasis, they will take the history of the patient, they will do examination, and they will individualize. Maybe with an individualized approach, they will suggest whatever the kind of screening that is required. But that will be not at booking visit, because obstetric cholestasis doesn't happen at the booking visit. It happens in the
Got
usually
it,
at
ma'am.
the third trimester of pregnancy. So it will not be done at the booking
Right, ma'am.
visit.
Right, ma'am.
Okay.
And one query, yes, ma'am. And one more query regarding the thromboprophylaxis. So when the protein excretion is more than 5 grams per day, then we start the heparin. And we refer to nephrologist when the protein excretion is more than 0.5 grams per day. So one is zero point 0.5 and one
Yeah.
is 5 grams, right, ma'am?
Yes. Yes.
Thank you, ma'am.
Okay. So now you guys can do the questions. I have put few of the questions for the guideline revision. So, patient type 1 diabetes attends the clinic at 10 weeks. Uh, you have discussed diet, exercise, glucose, and like what is the glucose monitoring and target blood glucose levels? What is one is the option is correct with regards to her plasma glucose level target levels?
Ma'am, the 1 hour post meal 7.8.
Yes, it is 1 hour post meal 7.8. Now, a patient poorly controlled diabetes, recent glycosylated tests are given. At what level you will not want them to get pregnant?
Above 86.
Yes, above
Yes.
86.
More than 10.
Yes. Now, the patient with BMI 38, family history of diabetes, attends clinic at 28 weeks. She has GDM and glucose tolerance is fasting 7, 2 hours 8.9. So, what is the most appropriate intervention in managing GDM in her case? How would you manage?
B, ma'am.
Diet exercise, insulin,
Ma'am, B.
metformin.
Yes, it will be B because it is more than 7. So, you have to add insulin and metformin plus and minus. Now, type 2 diabetes patient, and what will be the target capillary plasma glucose 2 hours?
C, ma'am.
I'm C 6.4.
C 6.4.
Yes, because they are asking 2 hour. So 1 hour is 7.8. Okay. Someone who said it wrong. So this is the answer. So fasting 5.3, 1 hour 7.8, 2 hour 6.4. So here answer will become C. Now the patient with ketoacidosis. Now what will be the threshold of ketones to confirm the diagnosis?
3 millimole per liter.
3 millimole per liter.
Yes, D. So blood ketones more than 3, urine ketones more than 2, blood glucose more than 11, and bicarbonate less than 15. Okay, so the patient is diagnosed with GDM at 24 weeks. She's modified diet, exercise, but still 2 weeks after regime it is elevated. What medication you will give?
Metformin, ma'am. I.
Metformin is the answer. So first it will be diet and glucose, exercise, then it will be metformin, that will be insulin. Okay, what I have done. The same question. I think the answer has come before. So this also I wanted to give you update that glibenclamide has been removed from the guideline. We have removed glibenclamide from this guideline. Okay, so the patient has persistent glycosuria when glucose testing. What will be the immediate treatment?
Insulin.
Insulin, fasting 7.1.
Yes, insulin, because it is more than 7, so you have to act fast. So insulin will be the choice. Insulin will be the answer. And pH insulin, because that is a choice that guideline want asking for. So 29-year-old woman suffering from type 1 diabetes. She is concerned about the ill effect of diabetes in the pregnancy. Advise the blood sugar levels. She should aim for getting pregnant.
A. Fasting glucose 4
Ma'am,
to
B.
7.
B fasting because 5 to 7, preprandial 4 to 7.
A.
Yes, B, B, no, B in B fasting. So fasting is 5 to 7. Okay, so fasting is 5 to 7, and 1 hour before meal or before meal or pre-prandial it is 4 to 7. So this is 5 to 7. This is 4 to 7. Here it is reverse. It has been given. So answer is B. So 32 weeks of gestation, diabetes, following gestational diabetes. What will the recommendation during pregnancy? So now it is GDM. Easy formula.
5.6, 5, 6, 7, 8. E.
5,
And
5, 6, 7, 8. Okay, what I wrote. Recommendation.
7.3, 7.8.
Okay, why not E is the answer? Because it is 2 hours. Okay, so 5, 6, 7, 8 is 1 hour. So this is 5, 6, 7, 8, 1 hour, and 2 hour is 6.4. Okay, so this is C is the answer. So even this mistake can happen. So 5
Fasting 5.3, ma'am.
Actually, they are asking targets in the pregnancy, and 5, 6, 7, 8 is the level for diagnosis.
Ma'am.
Okay, so therefore, I also said it wrong. So fasting 5.6 more than, and yeah, 2 are more than 7.8. It is if we have to diagnose GDM. Now, if the diabetes is already there, and so target level in pregnancy, so these are the target levels in the pregnancy. Here the patient is already pregnant, so they are asking about the they're asking about target level. So these are the target levels:
This is
fasting 5.3, 1 hour 7.8, 2 hours 6.4. Okay, so the answer becomes C. Is it clear?
Yes, please.
dirhams.
Okay, the patient has GDM. Someone's mic is on. Please, if you could
ये देख के बोलने लगता है पता है सच कह रहा हूँ
Link
please
भेज देना.
mute yourself. Okay, so a 35-year-old woman, gestational diabetes, gave birth to infant 4.2 kg, returned to clinic 6 weeks postnatal. She had just a blood test. What result will indicate that she would require to see whether she has type 2 diabetes?
Fasting group is
What they want to see? Check postnatal. What they will do?
fasting blood sugar.
Fasting blood sugar. So fasting blood sugar more than 6. So
More than
according to
6.
the yes, fasting blood sugar, if it is less than 6, they would have annual test. If it is in between 6 to 6.9, she's a high risk of developing diabetes, so they will be offered advice for prevention of diabetes. If it is more than 7, they have diabetes, so treatment will be done. Okay, now 27-year-old woman in second pregnancy. In first pregnancy, she had emergency cesarean section, failure of progress, and the baby weighed 4 kg. She has an oral glucose tolerance test done showing 7.2, 2R is 10.8. So what should be done?
Insulin administration.
Insulin administration.
No. And she has to undergo HbA1c also to find whether she's already diabetic.
So fasting baby. So fasting is high, and so she is diabetic only.
Insulin administration. Okay, ma'am.
Start with insulin.
A is the answer.
A should be the answer. Yes.
Hmm.
Why I have so she's already diagnosed case. So insulin to be an answer. Okay, insulin dependent diabetic patient attends combined clinic for follow up. Have inadequately controlled hyperglycemia with an increasing level. What to be done? What you will do? Patient is insulin dependent. Sugars are uncontrolled.
Increase the insulin dose.
Yes, so you have to increase the insulin dose. So because the patient is insulin dependent, that means that they are asking about type 1 diabetic patient only, because type 1 patients are their sugar control depend on insulin. So diet control gestational diabetes in antenatal clinic 33 weeks, symphysiofundal height 37. So what you will do? And sugar levels are increasing despite of the good dietary restrictions. So what do you do?
Insulin administration.
Yes. So this patient, they are giving a picture of polyhydramnios. If the patient has already having a polyhydramnios, that means totally uncontrolled diabetes. So give her insulin. 30-year-old with stillbirth in previous pregnancy found to be undiagnosed diabetes. She is on hypoglycemics, good glycemic control, attended pre-pregnancy counseling. What should be the next step? What you will do for this woman? She has come for pre-pregnancy counseling. She is
Check
diabetic.
glycosylated hemoglobin.
Yes, check her
HbA1c.
control. So check her control whether it is she's having controlled or not. Okay, 28-year-old primary gravida with diabetes. She is type 1 diabetes on insulin, BMI 28. And now fasting is 6. Glycosylated hemoglobin is 43. She monitors blood sugar level and she undergoes annual retinal testing. So what you will think? What should be done? So everything is fine. So what you will do?
Ma'am, folic acid, diet, exercise along with monitoring.
Yes. So she has to
D.
continue on monitoring. So folic acid and diet. Very good. Now 34-year-old patient, BMI 28, polyhydramnios, oral GTT 75, glucose is 7.8, glycosylated hemoglobin is 8, renal parameters are normal. So what to be done?
Insulin treatment. Fasting
Yes,
with
it should be insulin treatment. Polyhydramnios, so insulin treatment would be the answer. Now the patient is 39-year-old patient and growth scan at 37 weeks, first pregnancy fetal demise. She is type 2 diabetes with insulin and metformin. BMI is 30. Her more recent profile shows fasting 6, glycosylated 48, and the ultrasound within normal limit with the AC shows 97 centile. So what you will do? Everything is fine, but the patient, there is fetal complication you are looking at. So what you will do? If the fetal complication is there, so
induction of
what will
labor.
be your aim? Yes,
Induction of labor.
induction of labor. If the fetal, if the though in type 1, type 2 diabetes mellitus, they want patient to deliver anywhere between 37 to 39 weeks of
Sorry.
pregnancy, but they
Yeah.
can do it early if there had been any complication. Patient is already 37 weeks, polyhydramnio, like a macrosomia baby, so do induction. So offer induction of labor. Okay, so 30-year-old woman attend antenatal clinic with nuchal translucency report. She developed GDM in previous pregnancy, was on metformin. She had emergency section at 39 weeks. Her blood sugar levels are completely normal 6 weeks post delivery. Now she has come at 13 weeks. What to be done?
OGTT.
OGT. According to new guideline, if the patient has previous GDM and she is coming next time, so as early as possible, either she will do her glucose testing herself, self testing of glucose, or OGTT. So this is the answer. That's all about it. So any one of you have got any question can ask. Any question, people? Okay, so thanks for joining.
Thank you, ma'am.
All the
Thank you, ma'am.
welcome.